The diagnosis is made between 13 and 23 weeks. Before 13 weeks of gestation, a transient club foot can be present as a part of normal development. Wait for the foot to move away from the uterine wall to avoid false positives from fetal positioning. An abnormal position should persist throughout the scan. Extrinsic factors that contribute in the formation of CTEV include oligohydramnios, breech presentation, Mullerian anomalies, multiple gestation, amniotic band syndrome, and amniocentesis, which is done before 15 weeks of gestation. So recurrence risk after birth of one child with CTEV is quoted as 2 to 3%. If one parent is affected, then the recurrence risk is 3 to 4%. If both a parent and a child are affected, the recurrence risk can be as high as 25%. So when a club foot is detected, invasive diagnostic testing must be offered. So depending upon the associated ultrasound findings, we can offer CMA, FISH, or karyotyping. If there are additional abnormalities, consanguinity, or a family history of a specific condition, we can offer exome sequencing. Isolated cases have excellent prognosis and they are treated with a conservative Ponseti technique. So moving on to the next alignment abnormality in the lower limb is the congenital vertical talus or the rocker bottom foot, which is a rare foot anomaly. It is characterized by a prominent calcaneus and a rigid forefoot and dorsiflexion. The key associations are trisomy 18, spinal anomalies, and arthrogryposis. In contrast to CTEV, this is rarely isolated. So sagittal view is the best to assess this anomaly. Bulbous heel seen protruding posteriorly with convex plantar surface, which resembles the bottom of a rocking chair, are the diagnostic features. And foot should normally taper distally, but here the foot fans distally. So these are the ultrasound features of rocker bottom foot. In order to avoid, the diagnosis is usually avoided in the third trimester and when the foot is in contact with the uterine wall. So this fetus also has had persistent clenched fist. So these are, this features favor trisomy 18. This is the post-abortal picture confirming bilateral rocker bottom foot and bilateral clenched fist. So the next condition is posteromedial tibial bowing, which is a rare congenital anomaly of unknown etiology. There is shortening of the anterior crural muscles, limiting the plantar flexion of the foot. So there is severe acute hyperdorsiflexion of the foot, which is parallelly oriented to the shin of tibia. In severe cases, the foot may be nestled against tibia. So the bones of the foot and ankle are normal. It is always unilateral and isolated. This has a good prognosis. Normally, there is a spontaneous incomplete correction of bowing within the first 4 years of life. There may be limb length discrepancy, which may be treated surgically later in life. So this is a case of posteromedial bowing of tibia, where there is angulation of mid and distal third of tibia in the posteromedial direction. There is hyperdorsiflexed foot with calcaneovalgus deformity, as seen here. So this is the 3D rendering of the same fetus showing hyperdorsiflexed foot. So moving on to the next abnormal alignment, genu recurvatum. It's a rare condition affecting 1 in 10,000 live births. It is defined as a pathological hyperextension of the knee greater than 30 degrees associated with limited flexion. So it can be divided into two groups. It can be because of malformations involving anomalies of the elastic tissues or muscles, or it could be postural as a consequence of abnormal presentation or oligohydramnios. So it can be associated with multiple syndromes, particularly arthrogryposis multiplex congenita, myelomeningocele, Downs and Turner syndrome. Ischemia leading to fibrosis and contracture of quadriceps is the pathology behind this abnormality. So this is an example of postural genu recurvatum caused by a uterine septum, as shown in this 3D image. There was a uterine septum, and this is the postural genu recurvatum of the fetus. This is the post-abortal picture showing hyperextension of both knee joints. So this is arthrogryposis associated with gross genu recurvatum of both lower limbs. You can see abnormally pronated forearm and hyperflexed wrists here, which is suggestive of arthrogryposis. So this is again an abnormal positioning due to a partial uterine septum. The neck of the fetus was hyperextended to the extent that both the head and the abdomen were visualized in the same plane, and the feet were seen in the other side of the septum. So this is the post-abortal picture confirming the spinal abnormality and abnormal posture in the lower limbs. So this is a case of genu valgum with bilateral clubfoot. So you can see the opposing knees persistently, also called as the knock knees, and also bilateral clubfoot here. I could not find any literature showing prenatal diagnosis of genu valgum. So this is a very rare case. And moving on to the abnormalities of size. The first abnormality is proximal focal femoral deficiency with unilateral involvement of left femur. So here you can see there is abnormal bowing and shortening of proximal femur. And the other side femur is normal. So this is the post-abortal photograph showing the short left thigh and limb length discrepancy here. There is asymmetric absence of subtrochanteric femur, which may extend to the femoral head and acetabulum, and ipsilateral fibular hemimelia is a very common association. So next case is proximal focal femoral deficiency with unusual facies syndrome. So here you can see abnormally short bowed femur here, and there is also micrognathia with microstomia. The inferior facial angle was less than 40 degrees. So this is a case of congenital femoral deficiency. Both femora are not seen. So this is the very severe form of congenital femoral deficiency. You can see both the tibia and fibula, which is marked by the arrow, are arising directly from the hip joint. This is the video demonstrating the same. You can see both tibia and fibula are arising from the hip joint, and there is also bilateral clubfoot here. Moving on to the next size abnormality, you can see short stubby fingers here with a V-shaped separation between the second and the third digits, giving rise to the trident sign. So this is usually seen with achondroplasia or thanatophoric dysplasia. So this fetus also had pulmonary hypoplasia, and this is the post-abortal picture showing the trident sign with brachydactyly. So moving on to the next case, this is a case of ongoing BCDA twin pregnancy at 30 weeks. So the first striking feature was hypertelorism, exorbitism. There was also metopic sagittal and coronal craniosynostosis. So when we looked at the arms and hands for syndactyly, it was not there, but we found a prominent looking big tooth. So the differentials that we gave were Pfeiffer's and Crouzon syndrome. So another size abnormality is foot length discrepancy. This is a 26 weeks gestation with the foot length corresponding only to 22 weeks. The toes are not very well made out. And you can see the limbs are persistently in the semi-flexed posture here. And there was also persistently open mouth with thick lips and rounding of the corners of the mouth. There is also a flat facial profile. And the limbs were again in the persistent semi-flexed posture. So this diagnosis was Harlequin's ichthyosis. This is the post-abortal picture showing ectropion eclabium. And here you can see abnormally thick tight skin forming an armor and flexion contractures here that prevent the normal growth and movement of toes and fingers. And that's why we had foot length discrepancy in this case. So here we see a puffy looking feet here in the axial images. But in the sagittal images, you can see a clear subcutaneous edema in the dorsum of the foot in 2D and also demonstrated in 3D. So there was no abnormal vascularity within the lesion to suggest vascular malformation. And the anterior tibial artery and dorsalis pedis artery are well demonstrated, and that rules out ischemic causes. So this turned out to be a Turner syndrome. And the differential diagnosis is Milroy lymphedema. So moving on to the number of abnormalities of number. The first abnormality is polydactyly, which is defined as one or more extra digits in the hand or feet that may or may not contain bone. There are 3 types of polydactyly. Postaxial, which is more common, where the 6th digit is present on the ulnar or the fibular side. And preaxial, when the sixth digit is on the radial or on the tibial side. The polydactyly can also be central. In most of the cases, this is an isolated finding with an autosomal dominant mode of inheritance. In polydactyly can be found in 75% of the fetuses with trisomy 13. There are a number of syndromes that can be associated with polydactyly. So whenever a polydactyly is seen, parents should be evaluated, family history should be collected, and the location of the extra digit may be helpful in the identification of the syndrome. So this is the case of preaxial polydactyly. You can see a extra finger on the tibial side. So this is the rarer form and it's a part of macrosyndactyly. You can see that the extra digit is fused with the toe in this case. If it is present in the upper limb, it might be fused with the thumb. So moving on to postaxial polydactyly. This is a 22 weeks fetus showing very short ribs. You can see that this transverse section of the thorax, the ribs are not extending beyond 1/3 of the thoracic circumference. There is also polydactyly in foot and hand. So this is the short rib polydactyly syndrome. This is the post-abortal picture of the fetus showing polydactyly in all four limbs, bilateral genu recurvatum. And there's also dysmorphic faces with open mouth and protruding tongue. So this is encephalocele, cystic encephalocele with polydactyly and bilateral enlarged cystic kidneys, Meckel-Gruber syndrome. So this was the case of bilateral hydroerythronephrosis. This is the bladder, and posterior to the bladder, there's a cystic lesion with the echogenic structure within. So this was the fluid-filled distended vagina, and this echogenic structure was the cervix. There was polydactyly in upper limb and lower limb, and you can see internal echoes layering within the fluid-filled distended vagina. And this is the bladder, and these are the two hemivaginae. So this was McKusick-Kaufman syndrome. This is the postnatal photograph showing distended abdomen, and ultrasound abdomen shows fluid-filled cervix and uterus. So with these associations, the diagnosis of McKusick-Kaufman syndrome was made, and the baby underwent vaginoplasty following the drainage of hydrometrocarpus. So this is a Dandy-Walker malformation with bilateral polydactyly and transposition of great arteries. So whenever we see postaxial polydactyly with bilateral enlarged echogenic kidneys with a heart defect, we should think in terms of Bardet-Biedl syndrome, and this was proved with the whole exome sequencing in this case. So moving on to the next case, here you can see a left diaphragmatic hernia, colpocephaly, Viking helmet sign, supporting agenesis of corpus callosum, and this is polydactyly in both the upper and the lower limbs. This was the case of acrocalluxal syndrome. So this case had anhydromenous, completely absent liquor. You can see fused lower limbs with only a single bone, and bilateral fallen adrenal sign representing absent kidneys on both sides and single umbilical artery. So this was a case of Sirenomelia or mermaid sequence with fusion of lower limbs and feet. So there was syndactyly, which could not be made out due to anhydromenous. Polydactyly, sorry. So next number abnormality is syndactyly. You can see that there is syndactyly between the third and the fourth digits here. There is amniotic fluid between the second and the third digits, and the second digit is moving freely, but these two digits are not moving freely. So there was also marked disparity between the head and the abdomen, and there was also tetralogy of Fallot that you can see here. So karyotyping in this case proved digyneic triploidy. So syndactyly of middle two fingers is very characteristic of triploidy. This is the post-abortal picture showing the same syndactyly between third and fourth digits here. Next case of syndactyly. Here you can see this video clip shows syndactyly. The fingers are not made out separately. Demonstrated in this 2D and 3D image. There was also brain shadowing sign. coronal craniosynostosis with widening of the orthotopic metopic suture and dysgenesis of corpus callosum. So the diagnosis was Apert syndrome. So this is the post-abortal picture showing bilateral syndactyly and the towering skull. So this is another case. 1 second of. This is another case of abnormal number. Here you can see in this lower limb, there are only 3 digits seen. And the metacarpals and the phalanges are not ossified. You can see short, stubby, floppy fingers here, very short fingers and short toes here. In this 3D image also, it is well seen. So this is the post-delivery photographs of the fetus showing oligodactyly in this lower limb and disorganized toes and feet, toes in this feet, and short floppy fingers on both the upper limbs. So next number abnormality is ectrodactyly. So we could make this diagnosis of ectrodactyly in the first trimester because the mother gave us a history of claw hand deformity in the first child. So when we looked for it, we could find ectrodactyly in both the upper limbs. So this was confirmed in the anomaly scan also, both the upper limbs showing ectrodactyly. And there was also in bilateral foot, there was a absent central digit with deep median cleft and fusion of the remaining lateral digits, ultimately producing claw-like deformity. This is called as lobster claw deformity. This is the photograph of the previous child showing claw deformity in both the upper limbs. This is the photograph of feet of the father who shows us subtle cleft here. So ectrodactyly is also known as split hand foot malformation. It's a central ray defect that occurs because of the abnormal function of AER. It can be isolated or it can be part of ectrodactyly epidermal dysplasia or cleft palate syndrome. Familial isolated split hand foot malformation has an autosomal dominant pattern of inheritance with 100% penetrance and variable expressivity, as we see in this case. So here, the father had only a mild expression of the disease, whereas gross malformations are seen in the offsprings. So moving on to the abnormal movement, arthrogryposis multiplex congenita. This is not a diagnosis. This is a symptom complex, and it is seen in 1 in 3,000 live births. It can be a feature of abnormal neurological development or primary muscular disorder of the fetus. It can also be due to extrinsic causes like oligohydramnios, twinning, or uterine masses. Fetal arthrogryposis is defined as contractions involving 2 or more body areas. So normal fetal movement begins between 7 to 8 weeks of gestation, and this is important for the growth and development of craniofacial bones. So when this movement is impaired by any of the above mentioned causes, this can lead to craniofacial dysmorphia like retrognathia, lung hypoplasia, absent filling of stomach, polyhydramnios because of impaired swallowing, scoliosis, nuchal edema, hydrops, pterygia, and IUGR. So this is a case which shows the features of arthrogryposis multiplex congenita. You can see fixed flexed elbows and wrists with clenched hands. And there's also cross-legged position, also called as the Taylor's or the Buddha position. There is also persistent open mouth in the fetus, which is also called as the whistling face. You can see that the neck is abnormally hyperextended and the skin of the chin is continuous with that of the chest. So this was arthrogryposis, which was identified in the NT scan. You can see abnormally flexed elbows and flexed wrists. There was also scoliosis and cross-leg posture, and it was associated with increased NT. So whenever there is an increased NT with cystic hygroma, along with arthrogryposis, that indicates a lethal form of arthrogryposis. So this was a 22 weeks fetus. You can see pronated forearm with persistently flexed wrist here, an abnormal position of the foot also here. And you can see there is reduction in the muscle mass and the soft tissues show increased echogenicity because of the diffuse fibrosis. So this is also a case of arthrogryposis. This case was given by Dr. Jayaraman sir. So this is an abnormal band of tissue that you can see extending from the thigh to the leg across the popliteal fossa. So this is a popliteal pterygium with fixed flexion of the knee. So this is also confirmed in the post-abortal picture. So moving on to the abnormality of echogenicity, we have to look for the premature ossification of carpal and tarsal bones or epiphyseal stiffening. So in this case of 18 weeks of gestation, here we could see abnormal premature ossification of the coccyx, and there is proximal epiphyseal stippling here. The calcaneum should be ossified by 20 weeks, but here it is ossified between 18 to 19 weeks, and there was also binder syndrome. So this points towards the diagnosis of chondrodysplasia punctata. Now, moving on to abnormalities due to constriction, amniotic band syndrome, which suspected to be due to the first trimester rupture of the amnion, resulting in the amniotic bands that extend from the chorionic surface of the amnion to the fetus. So, fibrous band of tissue with a constricting ring and distal elephantiasis or protrusion of an uncovered bone is pathognomic of this amniotic band syndrome. So, this is a first trimester fetus where the fetus appears to be entangled in a net of echogenic bands, and there was also a cystic encephalocele and the abdominal wall defect. So this amniotic band syndrome would lead to bizarre non-embryologic limb, cranial, and thoraco-abdominal defects, also called as the slash defects. So this is amniotic band syndrome at 17 weeks. You can see thin linear echogenic bands radiating to the fetus. And here you can see edema in the dorsum of the foot, and the toes are not visualized. So this is the post-abortal picture confirming the diagnosis. You can see a constriction band here at the thigh, and dorsum of the foot is swollen, and the toes are amputated. There is no toes. So, conclusion, limb anomalies are one of the most common cause of medical legal litigations in India. Documentation of all three segments of all four limbs is of paramount importance. Hand and foot abnormalities should prompt a thorough search for syndromic conditions or aneuploidy. So thank you all for patient listening. Thank you, Manu. Will
Thank you,
archive
Dr. Roshi.
for us all to learn.
Thank you,
Dr.
Dr.
Roshi, really extensive, sir, and very, very comprehensive.
Yes, she was actually rushing through she has prepared many to tell, but she was actually rushing through because she had a lot of slides. She wanted to finish it off in time.
Okay.
Excellent
Sir.
presentation. It was a nice collection and a nice compilation, Dr. Roshni. Congratulations to you.
Thank you.
Pragnita, please, you can continue the proceedings.
Yes. Actually, anything in ultrasound is only pattern recognition. So first we should really learn about how to really know the abnormal from normal. So Roshni, can you just tell us how to systematically examine the limbs? Because that's the first thing we have to do.
Yes.
What do you do?
So as according to the ISWA guidelines, so all three segments should be documented. It's not enough that we just see the limbs. It has to be documented. Yeah, ma'am. So first, when we look at the humans, shall I share my presentation again, ma'am? Or should I show
the slide? You can.
Yep.
It will be better to document the limbs in the first trimester. First trimester scans are the ideal one to look at the limbs in all segments, both in sagittal and in coronal planes, and to see all the three segments. Yes, Dr. Roshni.
So yeah, we should always document the presence and symmetry and length. So this symmetry is done by eyeballing. So it can be done either like this when we document a coronal section of the entire limb, either the upper limb or lower limb, which rules out the limb length discrepancy, or we can document it in a side-by-side fashion, through which eyeballing is easier. So we can assess the symmetry of length of bones here. And we should also look at the alignment, as I said, the alignment of wrist with respect to the hand with respect to the wrist, and foot with respect to the leg. So movements should also be assessed. And sagittal images of the lower limb should be documented to look at the leg-foot angle, and end-face view of the foot should be seen. An open hand should be documented. And when we look at the humerus and femur, we have to look at the cutaneous contour, look at the underlying fat and the muscle mass. And this has to be extended up to the gluteal region.
Okay. There is one question from Dr. Vijay Kumar who has asked, is there any clues or condition where we need to do extensive scanning of limbs and any protocol for extensive examination of the limbs, sir? Yes, there are definitely clues which would warrant us to look at the limbs and the toes and the fingers. Like for in a case where there is a lateral shadowing sign in the skull, the APET syndrome, that will be the first one to, when we take the BPD, that will be the first one to alert us to the possibility of an APET syndrome, the lateral shadowing skull sign. And then when we look at the hands, we'll see the syndactyly of all the four fingers, the mitten, classic mitten hand. Similarly, acrocallosal syndrome, and there is an agenesis of corpus callosum, we'll have to look at the toes as well. And when we see, say, for example, in a case of Bardet Biddle syndrome, when we see echogenic kidneys, we have to confirm it by doing looking at the toe fingers. And similarly, Ellis Van Creveld syndrome, when we see a cardiac anomaly, we'll have to see at the upper limb and for the extra digits.
Actually, it goes both ways. Sometimes we might find clues in the finger, toes,
First,
and then it
yes.
other thing.
It may go around other way also. Yes. And Dr. Nivedita has asked, Nandita has asked, can arthrogryposis present in later gestation, which was normal in earlier scans?
It can present in later gestations. In fact, sometimes there may be only subtle findings, like just a club foot. That is why we tend to follow these cases to see if other joints are.
It can present in the later gestation, which is not seen in the routine early anomaly scan. I think there are no more questions in the chat box. So that was an excellent presentation, Dr. Roshni, and your place, your berth in the annual meeting of SFM is confirmed. You are presenting this in a concise manner, not in a full length.
Thank you, sir.
There are some more questions also pouring in. Do we need to measure all long bones? Can clenched fist be isolated? Dr. Praganita, do you need to measure all the long bones?
No, so I think it is sufficient if we just eyeball that and see them all mineralization, shape and contour is okay. But in some cases where we have short long bones, we tend to measure.
We'll have to. Yes. When we find a short long bone, we have to, and we suspect a skeletal dysplasia. When the femur length, foot length ratio is abnormal, then we have to measure all the long bones and to see whether all the long bones are short. Okay, then is Dilip Sharma who has asked about what about limb anatomy exam in second and third trimester anomaly? What does he mean by that? I don't know. Usually in third trimester, you are not looking into the limbs. They may be crowded, and if you are unable to say, you say that it's a growth scan, and one of the limbs, if they are shadowed and not seen, you can always comment that it is not seen during this period of study.
It is really important in third trimester that you mention that whether you looked at the limbs or not.
Yes. And Rashmi Rogi has asked, CTV unilateral or bilateral, does it make any difference in genetics with genetics? Bilateral, yes, bilateral is more commonly associated with the genetic abnormalities. Sir, can clenched fist be isolated? That is what one iPhone has asked.
Isolated is called isolated when we prove it is isolated. I mean, you rule out all the
other things,
technical and genetic, and then only you can call it isolated. So
it can be postural. It can have always cluster, but you look at the overlapping fingers, or that's quite abnormal. Roshni has shown clearly with the clinodactyly and the camptodactyly very well. When you see that overlapping fingers, it's definitely abnormal. Otherwise, when the fetus is keeping its fist clenched, I don't think it is abnormal. You'll wait for the fingers to open. Do we count all digits as a part of anomaly scan? I think Pranada will be the ideal person to answer because
it's always pattern recognition. You recognize that there are, if there is polydactyly, you instantly will know that there is a
yes.
wide thing. Then you start counting. Otherwise, it's really not necessary to count the fingers.
Usually, the many leading scans centers, they report that the counting of the digits were not done. They mention it clearly under the limbs that the counting of the digits were not done. So it is not mandatory that digits should be counted. This is not the part of protocol of the ISUOG also. ISUOG recommends you to only document all the 3 segments and not to count all the fingers.
Again, guidelines are just there for us to follow them. But if you really want to increase your diagnostic yield, you should definitely look at the fingers and make sure that
yes,
5. I mean, you not count them, but you should actually recognize the pattern.
Significance of isolated clinodactyly. Isolated clinodactyly is found in about 18% of normal individuals, normal fetuses. And it is quite common in Down syndrome fetuses. In some Down syndrome fetuses, is about 60%. But since the Down syndrome fetuses group is very, very less, so mostly when you see clinodactyly, think of isolated normal individual, normal fetus. So that's what the next question is also clinodactyly is seen often. What to report? You say that there's a clinodactyly and ask them to work up for Down syndrome in case if you are seeing other stigmata of Down syndrome. In our case, one of our cases, there was a clinodactyly, there was a absent nasal bone, there was echogenic bowel, plus I think increased nuchal fold. So that clearly points out to Down syndrome. So isolated clinodactyly can be abundant. It's about found in almost about 18% of normal fetuses. Okay. So that was an excellent session and it was well attended. Thank you very much, Dr. Roshni, for your abundant preparation and excellent presentation.
Thank you.
Definitely found a berth in the annual meeting. We are going to post this lecture in the annual meeting. Thank you very much.
Thank you, sir.
Final remarks by Dr. Pravanita.
It was excellent presentation, so really comprehensive. And we should always not just measure the limbs, but we should also look into them into detail so that our genetic and other associations are really brought out.
More importantly, when you are unable to see the limb, you have to document it in your report. When you are unable to see it because of the fetal position, when it is because of shadowing from other fetal parts, you'll have to document it in your report. That will save you from the medical legal litigations.
I think in anomaly scan, we should make every effort to see them, but in growth and it is really essential that we mention that we've not looked into the limbs.
Yes.
Excellent presentation, sir. Thank you for including us.
Thank you very much, sir. Thank you very much all for your patient listening up to this time of nearly about 9:30. I think, Roshni, you have rushed through all your slides because of you wanted to finish up within time. You could have dwelled upon some of the points which were.
We could have done just upper limb once and lower limb in another session.
No. That will be really boring. Okay. This was a very extensive dealing about limb anomalies without skeletal dysplasias. We'll have skeletal dysplasias in some other time. So thank you all very much. Thank you very much and good night. Have a nice weekend. Thank you.
Thank you, sir.
The recording may not be complete because in the middle we had YouTube streaming, which was actually disturbing. So the recording automatically stopped in the middle for about nearly 10 minutes or so. So the recording may be available from maybe the 15th minute of the lecture onwards to the end. Let's see if it is available, we'll upload it in the YouTube. But anyhow, excellent cases. Thank you very much, Dr. Roshni. Thank you.